the heaven, now your BP is more, 180. So this could be a white coat hypertension. White coat means in the unfamiliar surroundings and in a hurry, in an anxiety. The main cause is unfamiliar surroundings. In an anxiety, in a hurry, the BP may be falsely elevated. This is called white coat hypertension. Okay. And when you check the BP, home BP, the same patient, the BP may be normal. So this is, we call it as white coat hypertension. So if you do a 24-hour BP monitoring, you can diagnose this white coat hypertension patient. So again, the question comes whether to treat or not. That's a debatable point, whether to treat white coat hypertension, because in-house, they're normotensives. Only when they're coming to hospital, their BP is elevated. So some people do believe in treatment, some people don't. But some people strongly say that anybody having this white coat hypertension, they become hypertensive after a couple of years or 3 to 4 years. So therefore, you have to treat. Some people don't. Only lifestyle management they advise. So there are two schools of thought. One is white coat hypertension, you can diagnose. Second is masked hypertension. Masked, M-A-S-K-E-D, masked. Masked hypertension means it's just a reverse of white coat hypertension. In the house, it is more. When the patient comes to the hospital, it is less. I don't know what is the triggering factor that is raising his blood pressure in the house. You can imagine it could be wife, it could be husband, anyone. So there may be some psychological or any uncomfortable problems are there in the house. But this is called masked hypertension. So when patient comes to hospital, it is normal. In the house, it is more. So you kind of you can also pick up this category of hypertension patient if you are doing a 24-hour ambulatory BP monitoring. Third important point is a very important physiological point. I will come to the whiteboard. Arvas. The white coat hypertension can be a short question for you. See the normal BP. See, I'll draw here 120. Now I am drawing a normal healthy person's graph. This is 6 a.m., 12 noon, 6 p.m., 12 midnight, 6 a.m. So the BP is like that. There is an early morning surge, and then it comes down, then it goes like that. And again in the evening it is more, little more, and then comes that. And in the middle of the night, there is a dip. This is called nocturnal dip, physiological. This is physiological. Everyone should have this. This is called nocturnal dip, D-I-P. People who dip, we call them as the dippers, nocturnal dippers. Nocturnal dippers are normal people. So if you don't have this dip, if this is not there in some people, that's a risk for the future vascular problems. So non-dippers are dangerous. Non-dippers should be closely monitored for future development of hypertension. So somebody is non-dippers are dangerous people. That is one. This non-dipper also you can find out in 24-hour BP ambulance. And say, coming back to early morning, around 5 a.m. to 9 a.m., we have a surge. There's a dip here, there's a surge here, there's an increase in the blood pressure here. This is called morning surge of BP. S-U-R-G-E. Morning surge of BP. Morning surge also is a normal thing. But if some people will have exaggerated morning surge, that's why we get all acute MI and stroke patients during these hours, these peak hours, speaking hours, early morning surge. This is the time, morning 7 to 12, that is the time we get maximum number of heart attacks and paralytic attacks. Then second wave, the small wave comes in the evening around 4 to 5 p.m. So these are the two physiological peaks. But if they are more, if the people over respond to this kind of physiological changes, they become dangerous. So we should have a morning surge. All of us, we should have a morning surge. If morning surge is more than 30 to 40 mm, that is we call it as a risk factor for future hypertension, cardiovascular diseases. Second surge is small surge is in the evening, and this is the dipping. So all the things you will not know if you are checking your office BP or home or clinic BP. These three things can be detected in a 24-hour ambulatory BP. So you can detect white coat hypertension, then mask hypertension, morning surge, evening surge, and nocturnal dippers. So many variations you can diagnose if you by doing your 24-hour ambulatory BP monitoring. So that is very important, not only to diagnose what category of blood pressure your patient has and what kind of treatment you have to give and what kind of prognosis you are making. So at least once in a year, you have to do this 24-hour BP monitoring in the patients who are receiving antihypertensive therapy. Okay. So all patients have to take a proper history because as I told, family hypertension runs in families. So family history is very important, and you have to also inquire about their lifestyle. What is their lifestyle? How active they are in their day-to-day activities? Are they leading an active life, or they're homebound, not like simple housewife? They usually don't go out. They're limited to their house small activities. So are they eating excessive salt? As I said, we are all Indians are excessive salt eaters. Even if one time potato chips or one pickle curry or something will increase your blood. Even once, one time also, because it causes vasoconstriction. This whole salt causes vasoconstriction and water retention, causing increase in the blood pressure. So as less salt as possible should be advised. So there are again salt sensitive people, salt insensitive people. Not every, we have to ask every hypertension patient to reduce the salt intake in their food, but many people do respond to this salt restricted diet because there are two types of people: salt sensitive hypertension, salt insensitive hypertension. So we don't know from outside who is. We can do a test to know that, but basically, if you take less salt, it is always good. Of course, there are some drugs like steroids and